Good morning. Sorry for this thing. Actually, my videos are not playing on this, so I had to go with this actually. So I'll try to cover up the ablative part of the treatment. As we all know, hepatocellular carcinoma is a multidisciplinary approach to the treatment, which involves surgeons, radiologists, oncologists. The various treatment options available are the surgical resection, the liver transplant without the curative or the radical form of treatments. Then next to that you have percutaneous ablation procedures like alcohol and radiofrequency ablations, which are considered potentially curative methods. And then followed that you have palliative techniques like transarterial chemoembolizations and chemotherapy. Coming to percutaneous ablation therapy, it can grossly classify into different kind of ablation techniques. Basically a thermal ablation technique or chemical ablation technique or a non-invasive technique. Non-invasive means there is no injection of any needle into that. This is MR guided focus ultrasound, which is coming in a way. It's still evolving technique actually. What we in India use is commonly radiofrequency ablation for tumors which are amenable for this thing. Other technique which are there is cryotherapy. Now difference is cryotherapy uses a very low temperature of around minus 196 degrees centigrade to kill the tumor. Other is MR guided interstitial laser therapy is there, and microwave coagulation. This is still not very popular in our country. Other chemical technique is the ethanol ablation, which we commonly use in our patient where finance is a big issue, especially in smaller tumors where it can be used in less than 2 centimeter height tumors actually. So what are the indications? When do you need to do ablations actually? So basically look at it this way, you have a curative intent or a palliative intent. Now curative intent is those group of patients who have surgery, they are unresectable tumors in the early stage, either because of the patient comorbidities or very poor liver reserve. Or in patients as associated with a resection, you can use it in a bilobar disease where it can be used, or it can also be used as a bridge to a transplant actually. Palliative intent is one in which what we commonly encounter is relatively large tumors which cannot be operated on in intermediate stage according to BCLC, where you can use RFA and combine it with other techniques like transarterial chemoembolizations. This staging study has already been discussed. So what we commonly see in this group of patients is the intermediate stage, where we tend to combine chemoembolization along with radiofrequency ablations actually. So ablation, now I'll come briefly to radiofrequency ablation, the technique of it. It's very popularly used and it's very common, it's very commonly used in last decade or so. That's reason is because it is a very low morbidity and mortality associated with it. And number two, and very important, is it causes very effective tumor ablation or the tumor necrosis with preservation of the maximal normal liver parenchyma. That's very critical, especially in patients with underlying cirrhosis. You want to preserve as much of liver function as possible. The technique basically is you inject, you basically take a needle or the needle, which is like what we do for FNAC. We put it into the center of the tumor here, and then this is a multi-tine probe where you have multiple probes coming out to it. Now each probe generates heat. Now the idea is to generate heat as much as possible. The larger area you cover, the larger tumor you can burn. This technique is pretty useful in smaller tumors and also can be combined with other techniques like surgery or transarterial chemoembolization. The basic principle of radiofrequency ablation is like the cautery which is used. It basically passes high frequency alternating current through the electrode or the probe which you're going to put in here, which creates heat and destroys the tissue around it. It is known that if you can generate or increase the temperature of the tissue to around 100 degrees centigrade, it causes an instant cell death. Now this is the idea of radiofrequency ablation or most of the thermal coagulation system, ablation systems. This is how a small video on how the procedure is performed. Now, this is the liver where under either guidance or under open technique with open surgery, we can put in the needle into the tumor which is here. And once the needle is, it's a coaxial needle, you see multiple tines which comes out. Now, each tines acts as a heat probe, it generates heat and you try to raise the temperature. And after the ablation, what you see, the idea is to create an ablation zone or the necrosis almost 1 centimeter around the tumor. So if you have 3 centimeter size tumor, we tend to create a lesion of diameter of approximately 5 centimeter. At the end, we tend to come out with a track ablation. We ablate the track through which we had gone. Now, In larger tumors, a single ablation may not be sufficient, so you need to do multiple ablations here at the same setting. You can take out the needle, reposition the needle, and do ablations. In a larger tumors, more than 3 or 4 centimeter in size, we need to do multiple ablation at this setting. What generally patient will select are classical for radiofrequency ablations are tumor which are less than 3 centimeter in size. If the tumor is larger than 3 centimeter in size, we tend to combine it with transarterial chemoembolization, and we can take care of approximately up to 3 lesions and less than 3 centimeter in size. It can be done as a percutaneous approach, which is commonly done, or it can be combined with a laparoscopic technique or the along the open surgery. Now, these techniques are useful especially in patients where the tumor is subcapsular in location and close to very vital organs. Like if you have segment 5 or 6 lesion where the colon is very in close relation, you can use either laparoscopic open surgery technique, and under direct guidance, you can ablation can be performed. As percutaneous ablation, we tend to perform in general anesthesia, but it can very well be performed under local anesthesia. The advantage of general anesthesia is basically we get a better respiratory control and guidance. We can put in the needle in the correct position, which is sometimes difficult with the local anesthesia. This is one such patient where the ablation was being performed. Is done under general anesthesia. The needle placed, there's a right-sided tumor here, and the right lobe tumor. The needle is placed by the right subhepatic approach, intercostal approach here. And this was connected to the machine here. This is the ablator, radiofrequency ablator machine, which generates the heat. Coming to few of the illustrations, this is a classical small case here in the segment 5. You have a very small tumor out here, which post-ablation you can see a tumor which is large, the lesion which is up here larger and does not show any area of enhancement. So this is a classical, very good ablation in a patient with a small tumor actually. But rarely we've come across this kind of patient. Kind of patient which we come across are pretty advanced. You have an advanced cirrhosis here, a triphasic scan done. You have a liver, you have a tumor in the segment 7 here, almost subcapsular. There is ascites, there is splenomegaly, there is portal hypertension. So this patient, since the tumor was large, there are also comorbidity associated with it. There was a tuberculosis infection in the lung. We initially performed a transarterial chemoembolization in this patient, and subsequent follow-up, what we found was the alpha-fetoprotein, which was raised initially, had significantly dropped to almost 150, and then however on subsequent follow-up, what we found was there was a rising trend, and it was at this point of time we decided to put in a radiofrequency ablation because the tumor size is significantly reduced to less than 3 centimeter in size, and this is what the ablation, the intercostal approach here, the needle with the umbrella-like tines, multiple tines coming out. In the lesion, this is a sagittal projection of the same patient. As a follow-up of this patient after 3 months, what we see is there's a good ablation out here. These bright specks are basically the lipoidol which we had initially put in during transarterial chemoembolization, and you can see the alpha-fetoprotein level has come down significantly. But unfortunately, 2.5 years later, which is usually the story, there was a recurrence again at the same site, but this time it was a lot more aggressive and also had a thrombus in the portal vein, and the alpha-fetoprotein is also rising. At this point of time, it was the liver function was also deteriorating. She was in child C at this stage. There was a very bad, there were multiple collaterals as well. It was decided to go ahead with the transarterial chemoembolization, but somehow the patient refused, and she finally succumbed to her liver disease 6 months later. This scenario is pretty common where we see large tumors. Here again, another large tumor in again segment 7, almost 6 to 7 centimeter in size. With the palliative intent, we decided to do a combination of transarterial chemoembolization as well as radiofrequency ablation. Somehow, because of the technical region, chemoembolization couldn't be done because there is a tight stenosis at the original celiac axis, which we couldn't dilate. So finally, we ended up doing only radiofrequency ablation in this patient. What you can see, the ablation, the multiple ablations are performed, almost 6 ablations. And this is the larger size of the ablator area, which you can see. Sometimes we even need to do in patients just as a palliative, because it has been shown that even for a palliation sake, it can definitely improve the survival rate. This is one patient with alcoholic cirrhosis, young patient with hepatocellular carcinoma, already had radioembolization done, had a rising alpha-fetoprotein level, and it was insistent, though we refused, the patient insisted.
Dr. Jain, could you conclude in 2 minutes? Yeah? 2 minutes more.
Okay, thanks. So radiofrequency ablation was done. However, the patient succumbed 2 months later because of his infection. So it has been shown various studies that radiofrequency ablation definitely increases the overall survival in patients with unresectable SCC. This is one study which was published in 2005, which has shown the overall survival rate had increased almost 55% in this group of patients. One study which was published in JAMA in 2008, which was a large study, randomized controlled trial study, which had shown that combination of RFA with TACE had a better survival. You can see here the overall, there was a good survival here. Even in smaller tumors, they had shown a better survival. As far as the Indian perspective, I could find only one study which was available, and it is recently published in IGRI. This is from PGI. It's a small study with 31 patients over 6 years. They had shown a local recurrence rate of 16.1%, survival of 63.3%. Major complications they encountered was one person died because of hemoperitoneum, and that was so this very small study. We can't take much from this actually. Now the exclusion criteria are patients with a very poor hepatic functions. And the other thing is the technical feasibility, especially in patients with proximity to other structures like colon, is very important, which I already discussed. Another proximity to large vessel is another one where we need to consider, because this is the main cause for recurrence in this group of patients. Now, what happens is, because of the heat sink effect, once you ablate the tumor, because of the presence of a large vessel, the temperature or the ablation zone is smaller than what is expected. So this leads to recurrence in this group of patients actually. Complications which can be encountered are major complications include intraperitoneal bleeding, tumor settling, hepatic decompensation, portal vein thrombosis, but the rate of complications are definitely not very high. Chemoembolization we tend to combine. I'm not going to talk much on this. Basically,
Final slide, Dr. Jain. Final slide, 10 minutes talk.
okay, final comment. Basically, this is one patient I like to show is patient with where we did percutaneous alcohol ablation in patients with multiple recurrences of hepatocellular. This is a tumor here which had come up and for which ablation was performed. Now this patient again had a recurrence, another site which was again ablated. So in our setting, we tend to use percutaneous ablation because it's a relatively simple technique and we don't require very high expertise in this. So overall, what I'd like to say is RFA is definitely a potentially curable technique in early stage disease where surgery is not feasible. It can be combined with TACE in advanced disease, and surveillance and early diagnosis is the key to improving the clinical chances of survival in this group of patients. Thank you.